Hello, everyone. Welcome to our lecture on renal calculi, which is part of our comfort concept. So in this lecture, we'll discuss how renal calculi impact patient comfort and the essential role of nursing care in managing this condition. So from understanding the underlying causes to recognizing symptoms and providing effective interventions, this lecture will help prepare you to offer holistic and compassionate care to patients who are experiencing this very painful condition. Renal calculi, or kidney stones, form when crystals in the urine aggregate or clump together due to supersaturation. So let's start by defining some key terms first. So urolithiasis refers to the presence of calculi anywhere in the urinary tract. Nephrolithiasis describes stones that are formed in the kidneys, while uterolithiasis refers to those that are forming in the uterus. Dehydration is the most common condition that's associated with stone formation. This is because a lack of sufficient fluid leads to a highly concentrated urine, which promotes crystallization. Most kidney stones contain calcium, but there are other types of stones, including struvite, uric acid, and cysteine. So the process of stone formation involves two conditions. First, the supersaturation of urine with elements such as calcium or uric acid. So this leads to the crystallization of these elements. Second, a nidus, or a deposit of crystals, forms along the lining of the kidney or in the urinary tract, serving as the base for further stone growth. Other factors that contribute to stone formation include low levels of inhibitors in the urine that would normally prevent aggregation. Also, metabolic issues like hypercalciuria, which is caused by excess calcium absorption. And also extremes in the urinary pH, whether it be too acidic or too alkaline. So understanding these underlying mechanisms can help provide targeted interventions so that we can alleviate pain and prevent complications. All right, so just taking another look at the different types of kidney stones and their composition. So kidney stones form, again, when solutes in the urine precipitate and they crystallize. So the type of stone depends on which solute precipitates during the process. So again, the most common type is going to be a calcium oxalate, followed by a calcium phosphate stone. So these are often linked to high levels of calcium that are found in the urine. Uric acid stones are associated with acidic urine and conditions like gout. Struvite stones are less common and they're typically found in response to urinary tract infections. And finally, cysteine stones are rare, and they're usually linked to genetic disorders that affect the reabsorption of cysteine in the kidneys. So the diagram here highlights the anatomical structures that are involved in stone formation, from the kidneys to the ureters, bladder, and the urethra. So stones can form anywhere along this pathway, but their effects become most pronounced when the stones obstruct the flow of urine, which causes excruciating pain and potential complications. So by understanding the types of stones and their causes, we can better guide our patients in prevention and management strategies so that we can tailor their interventions to their specific risk factors and their health needs. Now let's go over some of the potential complications that are associated with renal calculi, which can arise from obstruction and damage to the urinary system. So first, any kidney stone can threaten the glomerular filtration rate, or the GFR, as well as kidney perfusion. So this happens when a stone blocks the flow of urine, increasing the pressure in the urinary tract. A hydroureter refers to the enlargement or dilation of the ureter, which is caused by urine backing up behind an obstructing stone. This can cause ureteral spasms, which are excruciatingly painful and may cause the patient to go into shock due to nerve stimulation. Hematuria, or bloody urine, is a very common result from a kidney stone. It's from the damage that's done to the urethral lining as stones move through the urinary tract. If the obstruction isn't removed, urine can then become stagnant, leading to urinary stasis, which increases the risk of urinary tract infection, which can lead to things like urosepsis. A persistent obstruction can escalate to hydronephrosis, which is the enlargement of the kidney that's caused by the accumulation of urine. So if it's left untreated, a hydronephrosis can result in permanent kidney damage. And you can see on the picture here what hydronephrosis really kind of looks like. You see that normal kidney there at the top of the image, and then on the bottom right side, you can see some very severe hydronephrosis where you see that big dilation and enlargement of the kidney. So these complications really show how important it is to have a timely diagnosis and to intervene so that we can relieve any kidney stone obstructions, manage pain, and prevent any sort of kidney disruption or kidney disease. So our goal as nurses is to monitor for these signs and to collaborate with healthcare teams so that we can prevent further harm to our patients. Now let's talk about the risk factors that are associated with kidney stones or renal calculi. So while the exact cause is usually unknown, there are several contributing factors. So first, we see a higher incidence in individuals who are assigned male at birth, and there's a strong genetic predisposition for stone formation. Family history plays a significant role because there are more than 30 genetic variations that have been associated with kidney stones. Also, a damaged urinary tract lining and a decreased or a highly concentrated urinary flow containing particles like calcium also increase the likelihood of stone formation. Metabolic defects are another major contributor, so these include increased intestinal absorption or a decreased renal absorption of calcium, increased production of oxalate, which is due to genetic factors, or the inability to metabolize oxalate from foods like from black tea, spinach, beets, and chocolate. Elevated levels of purines, which are seen in uric acid stones, are also a risk factor. Urinary pH plays a role too. So both high alkalinity and high acidity can encourage stone formation. Other factors include things like urinary stasis, retention, immobilization, dehydration, and decreased fluid intake. So our older adults in particular are at a higher risk simply due to the greater incidence of dehydration and other contributing conditions. Finally, our lifestyle factors, things like obesity, dietary choices, and even certain medications can increase the risk of a kidney stone. So it's very important to educate patients about these modifiable and non-modifiable risk factors to help them take steps toward prevention, especially if they have a personal or a family history of stones. So this table does a good job of summarizing the metabolic defects that can contribute to the formation of kidney stones, and it's categorized by primary and secondary causes. So we're going to start with hypercalcemia. So a primary cause is increased intestinal calcium absorption or that decreased renal excretion of calcium. Secondary causes of hypercalcemia include things like hyperparathyroidism, vitamin D intoxication, kidney tubular acidosis, or prolonged immobilization. Next, we have hyperoxaluria, which can be primary, linked to an autosomal recessive genetic trait that leads to high oxalate production. It also may be a secondary disease, where it's caused by a dietary intake of oxalate-rich foods, such as spinach, rhubarb, chocolate, and pecans. Hyperuricemia is another contributor. So primary causes of hyperuricemia are inherited disorders of purine metabolism, such as gout, where up to 20% of patients can actually develop uric acid stones. Secondary causes of hyperuricemia are things like increased production or a decreased clearance of purine due to conditions like a carcinoma or the use of certain medications such as a thiazide diuretic. Struvite stones are formed from magnesium ammonium phosphate and are often associated with urinary tract infections, especially those caused by Proteus mirabilis. So these stones require alkaline urine to be able to develop. And finally, cystinuria results from an autosomal recessive defect in amino acid metabolism, which leads to the precipitation of crystine crystals in the urine. So by understanding these different metabolic defects, we can tailor our prevention strategies such as dietary modifications, hydration, or medications to be able to address the underlying causes specific to each patient. All right, so getting into our nursing assessment and starting with our history from our patient. So we're going to begin by asking about their personal or family history of urologic stones. So a family history can provide insight into any genetic predispositions, while a personal history can highlight any pattern of recurrence or a risk. Next, we're going to get a comprehensive diet history, paying very close attention to fluid intake patterns. So are they drinking enough water to be able to dilute their urine? Also, we're going to ask about the use of vitamin or mineral supplements because excessive intake of calcium or vitamin C, for example, can contribute to stone formation. If the patient has a history of stone formation, then we're going to ask about any past treatments. So did they undergo a chemical analysis of the stone to be able to determine its composition? We're also going to ask if they've implemented any preventative measures, such as dietary adjustments or medication, so that they can reduce the risk of recurrence. All of this information helps us understand the patient's risk factors so that we can tailor our interventions to not only treat their current condition, but hopefully prevent future occurrences. All right, moving into our physical signs and symptoms of our nursing assessment. So the hallmark symptom of renal calculi is severe pain, often referred to as renal colic. So this pain can present in a few different ways depending on the stone's location. Usually it's the movement of the stone that causes the severe pain. So if the stone is in the kidney or in the upper ureter, the patient can experience flank pain. Then when the stone moves further down toward the ureters or the bladder, the flank pain may radiate to the abdomen, the scrotum, the testes, or the vulva. Importantly, pain, again, is most intense whenever the stone is actively moving or causing an obstruction in the ureter. Renal colic is usually described as being sudden and unbearable. I personally have never had a kidney stone, but I've cared for a lot of patients who have had kidney stones, and it looks absolutely like unbearable. As I said, it just looks excruciatingly painful. Usually the patients have symptoms that come along with their renal colic. They have nausea, vomiting, pallor, and they may also be diaphoretic. They may also have tachycardia and tachypnea, just as the body is reacting to the acute pain. When the stone reaches the bladder, then patients might report urinary frequency or they may have dysuria. If there is a significant obstruction, then it can also cause oliguria, which is very scant urine output, or even anuria, which is just the complete absence of urine. And that signals that there's a medical emergency happening. Also, we need to assess the patient for any signs of bladder distension, and we need to monitor their vital signs. So pain, as we know, can elevate vital signs, while infection may increase body temperature and the pulse. So in severe cases, with our vital signs, we may also see the blood pressure drop if the pain triggers shock. So early recognition of all of these different physical cues is very important so that we can provide the right interventions in a timely and effective manner. All right, now for the last part of our nursing assessment, where we're going to go over the laboratory and diagnostic assessment. So diagnosing renal calculi relies on a combination of lab tests and imaging studies to assess the stone's presence, its type, and its location. So a urinalysis, or a UA, is the key initial test. So by measuring the urine-specific gravity and the osmolality, we can assess hydration levels. The urine pH provides information about the stone's composition. High acidity is often associated again with uric acid or cystine stones, while high alkalinity suggests calcium phosphate or struvite stones. Hematuria, or blood in the urine, again, is a very common finding that's caused by trauma from the stone. And the presence of white blood cells and bacteria can indicate urinary stasis or infection, especially if the urine appears cloudy or if it has an odor. Serum or blood tests can further pinpoint any contributing factors, so elevated levels of calcium, phosphate, or uric acid can indicate metabolic abnormalities that may predispose a patient to a kidney stone formation. And a high white blood cell count here in our blood can signal a secondary infection as well. So imaging is essential for confirming the diagnosis and for guiding treatment. So the gold standard is a non-contrast CT scan of the abdomen and the pelvis, which provides very detailed images of the stone size, its location, and the surrounding structures. In some cases where a CT is not available, then a KUB x-ray, which is kidneys, ureters, and bladder, that's what KUB stands for, that can help identify any radio-opaque stones, although it's typically going to be less sensitive than the CT scan. An ultrasound can also be done, especially in pregnant patients, but it's not as effective for detecting any ureteral stones. Okay, moving into our nursing interventions. So nursing care for patients with renal calculi focuses on relieving the pain, preventing complications, and promoting the passage of those stones. So we're going to start by reporting all of our lab and diagnostic findings to the healthcare provider so that we can ensure prompt and accurate treatment decisions. If surgical intervention is needed, then we will also provide pre-op and post-op care. But some other things that we are going to do, we're going to administer prescribed medications such as analgesics for pain management and spasmolytics to help ease those ureteral spasms. So in the first 24 to 36 hours, pain is often at its peak, and medications like opioids or NSAIDs may be necessary. We're going to monitor for side effects, especially with those NSAIDs, which can impact kidney function. We're also going to encourage our patients to strain all of their urine. This is so that we can check for any passage of stones. And any stones that are passed need to be saved and sent to the lab for analysis so that we can find out what kind of stone it is. And this can just help us with preventative strategies in the future. So hydration is going to be key. We also want to advise the patient to increase oral fluid intake to 3 liters per day unless it's contraindicated. And for any additional comfort, we might suggest the use of a hot or warm bath or some sort of moist heat to relax the muscles and help alleviate pain. If the patient's not able to drink fluids, then we may need to administer IV fluids to help maintain hydration and support kidney function. We're going to encourage ambulation because physical activity can help promote the passage of stones. We may need to remind patients that smaller stones, less than 5 millimeters, can often pass without the need of any invasive intervention. And finally, we're going to assess and monitor the patient's pain status, their intake and output, and their urinary pH to evaluate our treatment effectiveness and to detect any complications early. So effective pain management is a priority for patients who are experiencing kidney stones or renal calculi, especially during the acute phase when pain is at its peak. So we're going to go over some of the key medications in managing this pain. So analgesics are commonly prescribed, and we usually have opioids like morphine, which are administered IV or IM. These are particularly useful, again, those first 24 to 36 hours whenever the pain is the most severe. We can also utilize NSAIDs like ketorolac. These are very, very effective for kidney stone pain. In my experience, a lot of patients get relief just from the Toradol or the ketorolac. So we try that first before we move to something like morphine. However, it's important to note that these NSAIDs carry a risk, including potential impairment of kidney function and kidney perfusion. So we want to monitor these patients carefully, especially in those who have any pre-existing kidney conditions. We can also administer spasmolytics, like oxybutynin. So these are used to relax the smooth muscles of the ureters, which helps reduce spasms and can actually ease their discomfort. In addition to pain relief, some other drugs can assist in managing the stones. So thiazide diuretics can help by increasing urine flow and reducing stone-forming substances in the urine. And then allopurinol is very effective in reducing uric acid levels, especially for those patients who have uric acid stones. So it's important to administer these medications as prescribed and to monitor the patient's response, asking them to rate their pain on that pain scale. And then adjustments should be made as necessary to ensure the patient's comfort and their safety throughout the treatment process. So when stones are too big to pass on their own, or whenever the pain or infection or the kidney function is at risk, then extracorporeal shockwave lithotripsy, or ESWL, may be indicated. And this is a non-invasive procedure that uses sound, laser, or shockwave energy to break calculi into smaller fragments that can be passed more easily. So during ESWL, the patient receives moderate sedation and is positioned flat on a treatment table. So the lithotripter is aimed at the stone, which is precisely located using fluoroscopy. So shock waves are then delivered in synchrony with the patient's cardiac rhythm, which is monitored by a heart monitor or ECG at a rate of about 60 to 100 waves per minute over 30 to 45 minutes. So you can see the picture here on the screen. It's non-invasive. It's just they're positioned just under that lithotripter, and then the shockwave therapy is administered. So as far as our nursing care pre-procedure, we need to obtain informed consent. So we'll let the provider explain everything that's going to be done, but we just need to make sure they sign the form and they do in fact understand the procedure. We'll help with positioning the patient flat on the table. And as nurses, will assist with the application of any topical anesthetic over the site, which should be done about 45 minutes before the procedure starts. And then post-procedure, we will encourage the patient to strain all of their urine so that we can monitor for any stone fragments and we can assess for any gross hematuria, meaning a lot of hematuria. Monitoring the procedure site is something that we're going to do. So bruising is very common. And hematuria is going to be an expected finding. I want to take a second and kind of talk about this. So hematuria is expected, but what we don't want to see is a frank amount of hematuria where it's almost like a hemorrhage sort of thing. But we do need to let them know that a little bit of blood in their urine is going to be expected immediately after the procedure. So in some cases with the ESWL, a ureteral stent may be placed before just to help facilitate the passage of stone fragments. And this procedure is generally well tolerated and highly effective, helping patients to manage stones while avoiding more invasive interventions. So if a patient is not a candidate for a ESWL, and when the stones are too large to pass naturally or they cause significant obstruction or risk to kidney function, then sometimes a minimally invasive surgical procedure might be needed. So we'll discuss 3 key procedures here. So stenting, ureteroscopy, and percutaneous approaches. So first we have stenting, and this involves placing a small tube in the ureter through ureteroscopy. So the stent dilates the ureter, which enlarges the passageway for stones or fragments. This procedure minimizes contact between the stone and the ureteral mucosa, which reduces pain, bleeding, and the risk of infection. A Foley catheter may also be used to help facilitate the stone passage. Next is a ureteroscopy, and this is an endoscopic procedure where a ureteroscope is passed through the urethra and the bladder into the ureter. So stones are then removed using a basket or forceps or a loop. Lithotripsy can also be performed during a ureteroscopy to help break stones into smaller pieces. And again, sometimes a Foley catheter can be used here to help aid in some of that stone fragment passage. Finally, we have a percutaneous uterolithotomy or a nephrolithotomy. And this involves removing stones through a small incision in the skin. So these procedures are often used for stones in the ureter or the kidney. Under local or general anesthesia, a needle is going to be inserted into the kidney with the aid of fluoroscopy, creating a tract for stone removal. Intracorporeal ultrasonic or laser lithotripters can also be used to help break up the stones before removal. A nephrostomy tube is often left in place post-procedure to prevent any fragments from passing through the urinary tract. After these procedures, we want to closely monitor for any complications like bleeding, pneumothorax, or infection. Nephrostomy tube drainage should be assessed for volume and for any blood presence, which is normal in the first 24 to 48 hours. We want to ensure sterile dressing changes and flushing as needed. So these, again, are minimally invasive approaches that can offer effective solutions to help manage complex kidney stone cases, helping patients to achieve relief and have improved kidney function. So this slide, we're just taking a closer look at 2 of the minimally invasive procedures to treat kidney stones: percutaneous nephrolithotomy and ureteroscopy. So with that percutaneous nephrolithotomy, or PCNL, this again is a surgical approach that's used to treat large or complex kidney stones that can't pass naturally. So again, this procedure involves creating a small incision into the skin to access the kidney. Then a nephroscope is going to be inserted through a hollow tube to locate and remove the stone. In some cases, ultrasonic or laser devices, again, are also used to help break up the stone into smaller fragments so that they can be extracted easier. On the other hand, a ureteroscopy, again, is a endoscopic procedure that's designed for stones that are located in the ureter. The ureteroscope is inserted into the urethra, into the bladder, to be able to access the ureter. Once the stone is visualized, then it's retrieved with the basket instrument, or it may be broken into smaller pieces using that laser lithotripsy. So both of these procedures are very highly effective, but they're selected based on the stone's size, location, and its complexity. Usually, after these interventions, patients have significant relief and improved renal function. Post-procedure monitoring for complications, such as for infection or for bleeding, is very important to ensure the patient gets a smooth recovery. So now let's go over open surgical procedures for kidney stones. So an open surgery is typically going to be reserved for large or impacted calculi that can't be removed through other less invasive approaches. So there are three primary types of open procedures. We have a ureterolithotomy, which involves entering the ureter, a pyelolithotomy, which targets the kidney pelvis, and a nephrolithotomy, which involves accessing the kidney itself. So these procedures are major interventions and are considered only when the other options have failed or when there's a high risk of permanent injury to the kidney or to the ureter. So pre-op care is very important for preparing the patient both physically and mentally. So we're going to explain the procedure thoroughly. We're going to tell the patient what they can expect to see, hear, and feel before and after the surgery. Patients will also need to maintain an NPO status, and they may require a bowel prep to be able to ensure optimal conditions for surgery. Post-op care focuses on recovery and monitoring for any complications. So checking for signs of bleeding from incisions or in the urine. We're going to also ensure adequate fluid intake so that we can support hydration. And we're going to implement infection control measures so that we can reduce the risk of post-op complications. Monitoring for the passage of stone fragments is very important, as is educating patients on the prevention of future stone formation. So this education typically includes dietary adjustments and maintaining consistent daily fluid intake so that we can avoid dehydration and that supersaturation of minerals that lead to the stone formation. All right, so getting into our last bit of our nursing intervention here, which is going over patient and family education, which is important in managing recovery and preventing complications. So first, it's very important to teach the patients to complete their entire course of prescribed antibiotics to prevent urinary tract infections. We're also going to teach patients that they can resume their usual daily activities, but it's important to balance regular exercise with adequate sleep and rest. The timeline for returning to work after a kidney stone will depend on the type of intervention that was performed, as well as their personal tolerance and the directives of their provider. So this may range from 2 days up to 6 weeks. Diet and fluid intake are very important in reducing the risk of future stones. So depending on the type of stone that was removed, patients may need to take specific medications or make dietary adjustments. We're going to encourage the patients to drink at least 3 liters of fluid per day to dilute stone-forming crystals, promote urine flow, and to prevent dehydration. Monitoring urine pH as directed by their provider can also help track their progress with this. We want to explain to them that it's normal to experience bruising after a lithotripsy, and while bruising may be extensive, it should resolve over time. And again, like I mentioned earlier, the urine may appear bloody for several days after surgery, but any pain in the kidney or bladder area, along with fever, chills, or difficulty with urination, need to be reported to their doctor immediately, as this could be a signal for an infection or even the formation of another stone. And finally, we want to remind our patients to keep all of their follow-up appointments. These visits are important to monitor for infections, to perform repeat cultures, and to just ensure a long-term recovery success. All right, so to kind of wrap this up a little bit, we're going to kind of go over this graphic. So renal calculi, also known as kidney stones, form when there is an excess of crystal-forming substances in the urine that can't be dissolved. So there are several factors that can contribute to their development, including disturbances in urinary pH, low urine volume, decreased fluid intake, and certain dietary factors. So there are various types of kidney stones, with calcium oxalate and calcium phosphate being the most common. Other types include struvite, uric acid, and cystine stones. The location of stones in the urinary tract determines the symptoms. So stones that are in the renal pelvis are often asymptomatic and they don't obstruct urine flow, but stones that are in the ureters can lead to increased pressure, smooth muscle spasms, wall distension, and severe pain known as that renal colic. Nausea and vomiting are also very common. Stones that move into the bladder can cause frequent and painful urination, chronic discomfort, or complications such as hydronephrosis, reduced kidney function, or even pyelonephritis. So to diagnose a kidney stone, imaging studies such as CT scans or x-rays, along with ultrasounds or even MRIs can be used. These just help visualize the stones as well as their impact on any surrounding structures. And then treatment depends on the size and the type of the stone. Options include NSAIDs for pain relief, as well as opioids, IV fluids to promote hydration, and medical expulsive therapy to help pass the stones, lithotripsy to help break the stones into smaller fragments, and an endoscopic procedure, which may be used for direct removal. So by understanding all of the contributing factors, the types, and the available treatment options, we can help manage kidney stones effectively and reduce their impact on our patient's health.